Welcome, everyone, to Leadership at the Point of Care, Clinical Delegation, Supervision, and Teamwork, Part 1. And so this is Ruth Hanston, and I'm going to introduce myself and talk a little bit about the work that we're going to be doing together today as we get started with this work. So I hope all of you have downloaded your handouts and that you can see our screen in front of you, and that you're able to have those in front of you as we go ahead with the conversations today. First of all, a little bit about myself. If you don't know me, I'm Ruth Hanston, and I've worked with about 175 organizations nationally now related to their care delivery models, and certainly many of them with clinical delegation and the point of care models that they're using to help make sure that RNs and assistive personnel and interdisciplinary team members work together effectively. I've written 6 books. You can see 2 of them in front of you there, Clinical Delegation Skills in its 4th edition, and my Relationship and Results-Oriented Healthcare Planning and Implementation Manual that talks about a shared mental model for making sure that delegation and supervision works effectively. Also, another book that we'll actually look at later a little bit is Home Care Delegation Skills, which I published with also Ginny Kenyon, who is a home care specialist, RN. My doctoral research focused on critical thinking and clinical judgment. And so a lot of the methods that we use in helping people learn about their work so that their clinical judgment is better and clinical reasoning is better, but also for the way we work together effectively as team members is based on what I learned about how people make decisions and think about the work that they do. So the objectives for this first part of clinical delegation training is to first look at the top 2 reasons why you should care. You know, for improving teamwork and leadership and delegation, what does the evidence tell us about that? Secondarily, we want to certainly define delegation and supervision so you're aware of what that is according to the National Council of State Boards of Nursing and also your State Practice Act. You'll know where to look that up. We'll also remind ourselves of the 5 rights of delegation and supervision. Our next core sections that you may opt to work through is the blueprint for successful clinical supervision and teamwork, so more about care delivery models. And then thirdly, effective assignment making for RNs and assistive personnel. And this is in acute care that we're going to focus on there. How do you actually make assignments? So in our clinical delegation skills book, we go through a lot of other steps that we won't be covering today. And so, for example, knowing your world and understanding your own practice in the organization in which you work, understanding the changes that are happening in our world of healthcare and healthcare reimbursement. We talk about knowing yourself better and being aware of some of your own strengths and challenges related to being a supervisor and whether or not you like to give people instructions and give them feedback or not. Knowing what needs to be done, figuring out what is the right task to match with the right person, knowing your delegates, who are the people that you're working with, and how to really optimize use of their strengths and to identify gaps in their competency, how to communicate and resolve the inevitable conflict that does occur when we're working under high-stress circumstances, and then a little bit more about giving feedback and evaluating and critical thinking and problem solving. So there's a lot more to this very complex critical thinking skill of delegation and supervision, but what we'll focus on are the basics in this particular part 1 of our coursework. Important resources. The National Council of State Boards of Nursing, ncsbn.org, has a wonderful richness of resources. So if you go online and check them out, you will also be able to download the joint statement, which we have on your in your Hanston Learning Center, the joint statement with the National Council of State Boards of Nursing and the ANA. So we'll look at that in a little more detail, but that's a wonderful resource for you to look at a decision tree. Your State Board of Nursing or Nursing Care Quality Assurance Commission will also be a wonderful site. You can connect to that from the National Council website. Also, you can put in your state and they'll be able to connect you. We have other resources that we're going to talk about, but I wanted to show you more detail now of this joint statement on delegation with the ANA and the National Council of State Boards of Nursing. You can see that there's this decision making about the nursing assistive personnel delegation. So the first step on the left is your assessment and planning, and then we go to the communication piece. So you can see that, are there laws and rules in place? If not, then you should stop. Yes, and you go down and make decisions around, how do we, not only how do we decide whether we can delegate, but how do we do that effectively and safely for our patients. Thirdly, that step 3 of surveillance and supervision and the step 4 of evaluation and feedback shows that we can't just tell people what to do, but we also have to watch to see if they're doing the work appropriately and correctly and completing it, and whether or not we're giving them feedback, and how do we evaluate and give that feedback. So that's available, and you've got that also as one of our resources online in the Hanston Learning Center. So to begin, let's do some reflection, which is that taking that time out to think about how do we work together effectively. So just to see whether or not there is anything that you think could be improved in the teamwork in your own organization, why don't you think about rating your own teamwork right now? To whom do you delegate? Who do you give instructions to? So depending on where you work, that could be a nursing assistant, it could be a patient care tech, it could be a home health aide, or maybe you're delegating to an LPN or LVN, depending on what state you work in. Thirdly, what processes do you use now to set up initial direction? Do you do shift report at the bedside, for example, in acute care? And at that point, you might be able to give initial direction to assistive personnel. In what ways do you observe or evaluate whether or not the care tasks that you've assigned are being done? And then, how do you have a point in time where you're offering both positive and negative feedback that's individualized to that particular person that you're working with? So these are some ideas to help guide you in your work in our discussion today about what it is that we do as a leader at the point of care. If you're in your handouts, you'll notice that on page 2 of your handouts, there are the learning objectives, and there are places there for you to actually write down some answers on critical thinking reflection to these particular questions. So if you haven't already done that, go to page 2 and make some notes there. So that will direct you in your listening and in your work through this online educational process. On page 3 of your handouts, and certainly in front of you with the slides, are the 5 rights of delegation and supervision. Under the right circumstances, so based on your setting and certainly what's going on with the patient and how much supervision is needed and how predictable the results are, we will be delegating or assigning, if you will, a task to a competent right person, and that right task has to be something that can be done based on their level of licensure and their competency and if they're checked off in your organization. And then we're going to give them that kind of direction and communication that's necessary for them to get started and to know when they should report back to us, so the parameters for reporting. Then we're also going to make sure that we're doing the kind of supervision and feedback that's essential for us to improve our practice and for them to also feel appreciated and a part of the team. So those are your 5 rights of delegation and supervision for best teamwork. Defining delegation. Delegation by the National Council of State Boards of Nursing is when you transfer to a competent individual the authority to perform a selected nursing task or activity in a selected situation. That selection is being done by the RN. So the nurse is then making that decision that the person's competent, that this is a good patient that we can actually delegate this task to this this nursing assistant or whomever, that this is something they can do effectively, and we're retaining the accountability for that delegation to make that decision. So that's that definition of delegation. Now, in Washington State, I've used some examples from different states, but in Washington State, either an LPN or an RN can do some delegation. Now, look in your Nurse Practice Act, because not all states allow LPNs or LVNs, licensed vocational or practical nurses, to delegate. So, again, it's competent individuals in selected situations. You'll notice that in many states that do allow delegation and that it's a part of your Nurse Practice Act and listed as such, that the definition will be similar to what is in the National Council of State Boards of Nursing delegation definition. The RN or whomever is delegating, in this case the RN or LPN in Washington State, retains that responsibility and accountability for the nursing care. So we're totally accountable for the nursing care of that client. And if you delegate, you must supervise. The other reason that I put this particular slide up here about delegation in Washington State is because in Washington and Oregon and some of the other states that there are specific rules about community settings, in-home care settings, group homes for the developmentally disabled, those kinds of settings where nurses are not regularly scheduled. There might be specific rules related to how you supervise and delegate in those areas. So be aware of that and look for that in your state. What about the states where you don't really delegate but you do assign? Well, for example, in Georgia, there's delegation is transferring authority to a competent individual for completing selected nursing tasks, activities, or functions, but they also say that they do not provide for delegation of licensed activities to unlicensed individual. So then they say, okay, what you do is you assign an individual to do activities within their authorized scope of practice. What is going on in your brain is very similar. The mental decision-making is very similar, whether you're not saying, oh, am I delegating or assigning? You're really just making sure that this is a person who's competent to do this activity, that it is something that is within their certification or scope of practice and job description, and then you're using the same kinds of initial direction, periodic follow-up, and evaluation and feedback, whether you're delegating or assigning. So that's just so that you can think about that if you have, some kind of a statement in your Nurse Practice Act that says, well, we don't delegate, we assign. So just FYI for those of you who might find that. Well, if we delegate and assign, we must also supervise. So what does that look like? What are the actual definitions? And you'll notice on page 4 of your handouts that I've got the National Council of State Boards of Nursing delegation definition, supervision definition, and then accountability definition as well. Supervision is when you provide guidance and direction, oversight, evaluation, and follow-up. So that's pretty easy to understand, certainly. If you actually look at Nurse Practice Acts or rules or advisory opinions that might be posted on your nursing board website, you'll find that there are sometimes more specific direction related to what is supervision. So here in Washington State, you can see that there are 3 steps that are listed to supervision. So initial direction of the task or activity, periodic inspection, and the authority to require corrective action. What I find is that nurses don't often understand that they do have that authority to require corrective action, and they're often waiting for a manager to do something about something when, in fact, they have the authority to make decisions about, and I'm not talking about a corrective action human resource form here. What I'm talking about is that if there's an error or a problem or something doesn't get done clinically, that the RN has the responsibility and authority to discuss that with the patient care tech or nursing assistant. So this shows us the parts, if you will, of supervision in the state of Washington, and it fits certainly with what we learned from the National Council of State Boards of Nursing. What I do want to point out here is that initial direction sometimes doesn't even happen. Nursing assistants come into people's acute care units and they just start work. And maybe they have a piece of paper with, they're supposed to write down vital signs, or they're just starting on vital signs. And what happens there then is there really, unless the off-going charge nurse says something, there really isn't appropriate amount of initial direction related to those patients. And what happens then is we've had examples where nursing assistants have told us about going into a patient's room and the patient's already expired and they have not been told. And certainly that can be horribly frightening to a new nursing assistant, and certainly even worse if there's a family member still sitting there. It shows a lack of respect, I think. So being aware of the parts of supervision, that's an important piece of what we do as registered nurses and leading at the point of care. Well, then there's that word accountability. Scares a lot of people because they think, well, that must mean I must be to blame for everything. And instead, we'd really like you to think about accountability as stepping up to the plate in a positive way and being proud of your licensure and that you have worked so hard to be a registered nurse and that you're okay with being answerable because you're making good decisions and that you're doing things well. So the other part of this is realizing that other people on the team have accountability as well. The person you're delegating to, or the delegatee or tech, is accountable for saying, yes, I know how to do this, I can do this, I will do this, and then his or her own actions in carrying out the task. So everyone on the team is accountable for doing their jobs appropriately. So let's look at a little bit more evidence related to point of care teamwork. And you see the words that are all jumbled up there on the screen, that there's so much that goes into making decisions about how we get the work done most effectively. And it uses a lot of emotional intelligence and feedback has to be given. There's so much that does go on. Look on page 4 on the middle lower part of the page there, and you'll see that some of the answers are there in front of you related to this team field evidence around teamwork. If we think about the Joint Commission and Sentinel events, so harmful events, how many of those are related to team communication? And the reality is that 60 to 80% of the errors and the problems that really cause harm to the patient are related to whether or not we're communicating effectively. Now, whether or not that's change of shift report, or that's patients being transferred to one area of care to another, or into the community and back into the hospital, it does mean that we're probably, even with our EMRs, we're not doing as good a job as we could with that kind of communication. Just recently, Joyce Benton had written an article about legal liability and minimizing risk exposures affecting nursing practice and patient safety, and this was in January of 2013. If we look at what the actual percentage of closed claims are, you can see that assessment and treatment and care were the highest percentage. Scope of practice was a very small percentage. So it's not a big issue, but sometimes the treatment and care isn't done well or effectively, or care is missed if we don't do good delegation and supervision and follow-up. What Joyce says is to be sure to follow your state scope of practice and Nurse Practice Act, and also, of course, the facilities policies and procedures, making sure that you really develop your own way of communicating effectively, so that there's a shared mental model in how you work together, so that everybody knows that, oh yes, this RN is going to be checking to see whether work is getting done and is going to be giving me feedback. That we also carefully communicate with our team members, and those handoff methods that we've already discussed are huge for making sure people know what they're supposed to be doing and that they follow through with those. And if you're not getting the results you want, you've given feedback to a nurse assistive person and it hasn't improved, that certainly you go to the next level and make sure that someone is following up with anything that could cause some patient harm. So let's look on next then to what we find in some of the other research. Standing and Anthony and some of their folks have done a lot of work on delegation and supervision. And we find that even novice nurses and seasoned nurses are uncomfortable with telling people what to do and following up with them. And if you really want teamwork to work effectively, there has to be, this is not a surprise to anybody I know, but there has to be trust. We have to be able to collaborate and assist each other. We have to be able to understand each other's roles and also recognize that, if there's a problem, we are all having to work to solve it together. I think one of the things I see frequently with assistive personnel is that because if we haven't walked in the other person's shoes, we don't really understand their roles effectively. They are perhaps unhappy because they have felt that their roles have not been appreciated and or that the RNs have been asking them to do things even though they are not comfortable or do not actually, quote unquote, get their hands dirty themselves. So they'll be upset because their patient had C. difficile and the patient was stooling all day, but the RN never came in to help with any of those cleaning episodes and, in fact, kept paging the person out of the room. And, those kinds of issues certainly don't help teamwork. So Standing, Anthony, and Hertz did a study to look at what happens, why are there errors when we use assistive personnel, or when are there errors? And they found that a certain percentage of that was related to whether or not the RNs were doing their jobs appropriately. So 13.9% were related to right direction or communication, and then 12.4% due to lack of supervision. So when outcomes are determined by routine observation, so if you have set up a method for doing the work together and getting in touch with each other before and after breaks, giving each other feedback, debriefing, when that's happening normally, then there are more positive events. And if there is just this parallel practice where people aren't really talking to each other, then there are more negative events. So keep that in mind. Our next slide really has, it focuses on when things go wrong. And you'll see on page 5 of your handout packet that you can look at some more detail on this. And you can see that we've shared this with the American Organization of Nurse Executives, and certainly I've shared it with some of the national webinars that I've done about this topic, because I wanted to try to draw this direct line between the processes that we do at the bedside and what those results are. So if you go to the far left and you see, when there's no focused interview, so the RN doesn't know the patients well enough, and then he or she does not give very good initial direction or planning for the care with nursing assistants. And for example, if there is a bedside shift handover, then things are usually done more effectively, because if the nursing assistant at least can be involved in one set of RN to RN handoffs, and initial direction can be given right away, and she or he sees the patient there, and there's a discussion including the patient in the conversation about, Joe, the nursing assistant, is going to be in here positioning you and making sure you drink and eat and getting you all cleaned up, because we want to make sure that your skin integrity is maintained and you don't get any bed sores. That kind of conversation makes a big difference. When I ask people about how long it takes before there can be a pressure ulcer beginning in a patient who's cachectic or has skin issues, or they're stooling and having incontinence, then it is 2 hours or less. If we don't take care of it within 2 hours or less, we end up with some initial signs of ulcers. So what that shows us, and if you look at the cost of that from a national perspective in the arrow, the second one from the right, the national cost is $13.9 billion. So this is almost $14 billion nationally, and this is just from, obviously, some people are at the point of death. We can't stop them. They'll have skin loss and all of that. But in these cases, 60,000 patients die a year. There are 6 to 10 days extra admission, and you can see that there's 3,000 to 52,000 per case, and that's $200 million of lost revenue. Because, if you think about what is happening now in our value-based purchasing in hospitals, we know that those patients, if they're not present on admission, we are not being paid for the care of those pressure ulcers. Now, if we miss the hydration, ambulation, nutrition, hygiene, all of these things, if those basic nursing care, Florence Nightingale tasks are missed, then we end up with these things. We can also have, besides a pressure ulcer, we can have thromboemboli, we can end up with the PEs, loss of function, patient having to go to a higher level of care, patients coming back into our ER, recidivism, and failures to rescue. One of the interesting things I've found as I've really looked into failures to rescue is that one of the last studies on that I saw evaluated what went on 24 to 48 hours before the patient became gravely ill and the rapid response team, or the code was called, that there were changes in vital signs, mentation, and functional status, and I&O that the nurse did not pick up on. So some of that might have been retrieved. That information could have been retrieved from perhaps, nursing assistants, but the nurses never put that information together. Our next slide shows the Swiss cheese safety model. And some of you are aware and have seen that James Reason talks about this when we started looking at the number of safety errors in hospitals, in particular in medical care, that there are certain processes that are defenses from an error or a hospital-acquired condition. And as you can see, these defenses, if we start at the very top, if these are not done, then the holes will line up and we're going to have an error or a hospital-acquired condition, for example. So here, if we look at whether or not RNs know their accountability, this is a big one because I think RNs, some of them don't understand that they have accountability, and unlicensed assistive personnel or UAPs don't always understand their own roles and that they are accountable for the work they do as well. If the team members don't know their patients well enough, then they're not going to be doing the kinds of basic nursing care that needs to be done. Sometimes it's in the assignment methods, and if we don't have a shared mental model for working together or a map or some kind of scaffolding for the way we work together, and the assignments have a direct line of authority with RNs and nursing assistants, then it's unclear who's supervising whom and what. And that does not make for good, effective, or efficient care, and it doesn't make for a happy team. If we have a plan that works in the normal amount of admission and discharge and all of that kind of churn that goes on, if we have a plan set up for that, it helps. If there's good initial direction with assistive personnel, setting up checkpoints, timelines, parameters for reporting, and really looking at before and after breaks and meals so that the RN can get feedback from the assistive personnel on how well they're getting through the actual tasks and what help they need, but also to get that feedback at a set juncture of the shift so that you're going to be seeing the person and they're going to report back to you about what was the blood pressure, what was the glucose, and so on. And that allows for better supervision. Then you've got a happy group who feels like they're making a difference and making an impact. The best teams do debriefing and feedback toward the end of the shift, where they celebrate the results and they really evaluate the work that has been done. So these are all pieces of teamwork that it really needs to be there for effective, efficient, and the best delegation and supervision. So what about if a delegate made a mistake? Let's say you asked a nursing assistant to do something and they made a mistake. Would that mean you could lose your license? Because that's, those questions are the ones that really frighten people, I think. Well, let's look at that. If you delegate, you have to be sure to delegate within your own area of responsibility. So you're not delegating something that's outside of your scope of practice. It's something that can be properly and safely performed by that person, and that it is, it would be something that anyone would think would be a reasonable thing to assign to that particular competent nursing assistant. It is always something that does not require nursing judgment. So it's a routine task. It's not something that in which the RN has to make, or the sister person would have to make make infinitesimal changes based on judging a wound, or I better do it this way or that way today. Not requiring nursing judgment. The RN has to make an assessment of the patient. She has to know the patient before he or she delegates and supervises, and then certainly instruct or verify competency. And again, in every Nurse Practice Act that I've looked at, it's clear that we are not giving away our nursing judgment. We're not asking someone to do something that requires them for making decisions related to how they're going to interpret the data that is in front of them. In Oregon, for example, the supervision definition says that we have to have initial direction and periodic assessment when we're supervising, and they list, as many states do, conduct that's derogatory to the standards, or, for example, what would be in your uniform disciplinary code for healthcare professionals. And they list that you must not assign a task that's beyond the scope of that person's practice, or if the person's not competent. And if you don't supervise or teach them, and if you improperly delegate it in a setting where the RN is not usually scheduled, we're talking about home care again and group homes and such out in the community. If you did that kind of delegating out there in that part of the community, you'd be in trouble with your license. So if we talk about how would you get into trouble with your licensure, it would be if you did not follow the 5 rights of delegation and supervision. So who's accountable for a mistake? Well, the person you delegate to is accountable for his or her own performance. And the RN is accountable for making that decision to delegate based on the best information available. For the patient, the RN is accountable for the patient care, the nursing care for that patient, for correcting the effects of the error, and for addressing that performance problem. I use the example of my second job many years ago. I had a nursing assistant who had decided to open the IVs up and dumped about 1,000 cc's of fluid into these patients within a short period of time, 3 different patients. And she thought that day that she didn't even realize she was going beyond her scope of practice. She just went ahead and opened them up because she wanted to do baths for these patients. Now, that was not my error. I did not instruct her to do IV therapy. And, however, I did immediately take care of the patients. I made sure she understood that what the effects would be of trying to do IV therapy, and that was beyond her scope of practice. And I addressed that performance problem. I didn't just say, oh, yeah, well, I'm not going to follow up with this. So it's clearly, that seems like a huge error, and it would be something that would probably never happen, but it did happen. And so it's good to think about any other kind of mistake that a delegate could make, as long as you're doing everything you can to make that patient in the best clinical outcome that is possible. So really making that patient safe, and for correcting the effects of the error and then addressing the performance problem because you do supervise the work that is being done. So here are 5 rights: the right circumstances, the right person, the right task, the right direction and communication, and the right supervision and feedback. Let's take a look at that then in a little bit more detail. So again, under the right circumstances, you're making your decisions based on not just the setting, because remember we had different rules for out in the community than inpatient acute care settings. The patient situation, how sick are they? What are they stable? Or how predictable are the results of this situation and the tasks you might be asking the person to do? How much supervision do they need? And are you available to do that supervision? Under those right circumstances, you are going to ask this right competent person. Now, how do you know if they're competent? You've got floats coming into your unit or your department. Look into your organization's checklists. Find out how many, what people get checked off on, what their job descriptions say. Look to see, are they certified, are they licensed? Sometimes you might ask them to demonstrate a skill if you've got the feeling that they really aren't sure about what it is that they're asking or you're asking them to do. So asking enough questions to find out that do they feel comfortable, what questions do they have? Open-ended questions like that will help find out if that person is competent. The right task. We have that wonderful decision tree, but remembering that every time we're making a decision about what task should be done, it is based on what results you expect to achieve from having that task accomplished. So if I'm asking for, I use the task of a blood pressure. So nurse-assisted personnel can do blood pressures. Okay, so that's pretty much standard. They can do those. So I have several different patients on the unit, and I'm trying to decide whose blood pressure should this nurse assistant take. Is this the right task for this competent person? And we're going to assume this person is competent to do blood pressures, and they're checked off, and so that's all cool. So what I'm going to decide is, why am I having these blood pressures taken? So if I've got a patient who is post-op patient who I think might be bleeding, I'm going in there because I hear that their blood pressure was down at the last check, and there's quite a bit of blood on that dressing, and I'm thinking, there's a missed bleeder. I am not going to probably ask the nursing assistant to do that blood pressure on her own. I'm going to be in there, and I might have them accompany me and take a blood pressure while I'm doing the rest of the check, if that's the best use of time. But I'm certainly not going to just let that person go off and do it unless I have a couple other patients that are coding. Really, it's a priority issue. Now, let's say we have a patient who's waiting to go to hospice, and there's an assigned, let's say, number of vital signs that are done for patients. Well, the patient's waiting to go to hospice. The family doesn't want a blood pressure done. We aren't going to assign that at all. So just because a nursing assistant can do a blood pressure does not mean you will assign that. I think it's very important to be clear about not making a rote assignment. The intended outcome for the patient who's a post-op surgical would be to find out what's going on clinically. And, for most of the other patients that would be similar, but this is a patient condition issue now. And so looking at that, a competence, again, the correct scope of practice, and the job description, those are all ways that we determine if this is a task that can be delegated. It certainly has to be within our own scope of practice before we could, and the person's ability and scope of practice in order to delegate that task. The right direction and communication. We use the example of those 4 C's of communication: correct, concise, complete, and clear. What we hear from nursing assisted personnel is that oftentimes the instructions are too concise. They don't get enough information to do a complete job. They don't know what is expected of them. we always encourage that you set up times where you're going to reconnect with the nurse-assisted personnel, and that is, before and after breaks and meals, and that there are times that you reconnect and say, look, I've done my patient-focused interview with all these folks, and these are the updates. What are you finding out when you were making your rounds? So there's guidelines and parameters for reporting so that it's very individualized for that group of patients that you're working together with. Right supervision and feedback. There has to be a two-way street here. We have to feel strong and say to the nursing assistant personnel, what could I do differently as your leader this shift or as a team leader with this group of patients? Please tell me, what more did you need to know before you could get your job started today? And what did you need help with? And let's talk about how we could do this better in the future. Also, be sure to celebrate those things that went well and give people feedback, specific feedback, not just, oh, thanks, that was a great day, bye. More into, I really appreciated how you worked with that family where the patient got the bad news today about the extent of their disease, and you were so compassionate. That was really cool. That kind of feedback is important. So a chance to celebrate, to debrief, to talk about what would we do differently if we were to work together tomorrow on these same patients, so that there's that two-way street of discussion rather than just people working in that parallel practice and not talking to each other about patients or about how they did as a team. So what are your next steps? And we have on page 6 for you, we have a list of questions for you to answer. And we'd like you to think about whether or not there are any gaps that you would like to address in your own practice. Do you feel that you are providing initial direction that is helpful, that shows what results that you want to have achieved, short of just doing a task? Is there an impact to the patient and family that's connected so that a nursing assisted person could know that if they don't actually go in and hydrate and turn and clean the patient, that there's going to be a decube, or they could get, if they're not ambulating them, we could have thrombosis and emboli and all of those things, so that they understand that. Secondarily, how do you set up checkpoints? When do you reconnect? Do you have a structure around breaks and meals that helps support people's self-care as well? And being sure that you have times to reconnect with each other. And then think about what steps you can take for better evaluation and feedback. How are you giving each other feedback? Are there things that you've kind of held back that were unmet expectations that you're a little ticked off about over the years, that you're thinking that person, I'd really like that person to still straighten up their act, and you haven't really talked to them? It's important to have some structure into your case-by-case and day-by-day processes so that it becomes a part of your norms and your teamwork to talk to each other about how things went. And then really, go into, how you can become more effective and comfortable at delivering any kind of feedback that you might want to deliver. So what are the common misperceptions? I think that one of the things that occurs not infrequently is there's an assumption that the bedside teamwork is just fine, even though, the RNs will say, gee, I give a lot of initial direction and feedback to people. I always tell them they're well, I really appreciated the work they've done and all that. And when we talk to the nursing assistant personnel, they're telling us, you know what, I don't think so, because I don't get enough information, I don't get enough appreciation, and so on. Another misperception is that a lot of folks think that all RNs and nursing assistant personnel understand their own accountability. I still hear nursing assistant personnel say, hey, I'm working under the RN's license, and so I don't really have to do anything. I don't have any accountability. And they don't see the impact of them doing or not doing their work on patient outcomes. I was working with a group last week, and as always at the end of a full-day workshop, I ask them about what are they going to do differently when they go back to work. And these were all RNs. And 2 of the RNs said, I'm going to give some initial direction to assistive personnel because they had not been doing it. So I think it's important that we realize that not everybody on the team may understand what's involved in initial direction and periodic follow-up and teamwork. Sometimes we assume that the model that I have in my brain of how this shift should go, and that structure is what everybody else has, and they may not. So if you were to ask the people on your shift, how do we, what do you think is working about the way we work together on our team? What things are getting in the way? What are the barriers? What are the gaps? If those kinds of questions were asked, then you might see whether or not people feel that there's a good structure for the work. Fourthly, I think that people believe that delegation supervision is taught in your undergraduate, before you get your licensure, and so everybody must be good at it. And in fact, it's a much more complex critical thinking process than most people understand. So there is a need for some coaching from time to time to help people be effective and really optimize their strengths. The other thing is that sometimes there's a failure to act on performance issues. So we encourage you to really look at some of the performance issues that might be getting in the way for teamwork and to help people on your team really act on and report and work through performance issues that might be occurring. Excuse me. Excuse me. So, common issues. What I find in my work nationally is that if we together on our unit councils, with all the folks in our organization really do some creation of a care delivery model or structure that helps people be more effective, that has some kind of structure for a way to give each other feedback and initial direction and periodic follow-up, if that's the norm, it does help people be more flexible in the midst of all the changes that occur in a hour-to-hour basis. So our next program we'll be looking at the blueprint for successful clinical supervision and teamwork, and to look into this a little more in detail about what could that look like in the way that we work together to set up that blueprint. We like to bring forward Florence Nightingale's words because she was a very, very wise leader of nursing, and she said, "Let whoever is in charge keep this simple question in her head. Not how can I always do the right thing myself, but how can I provide for that right thing always to be done?" Very bright, brilliant woman. So here's how to contact us, and we know that's available on the Hanston Learning Center, but here's some methods that you can contact us if you need some on-site consultation, conference call, or something to help make this online learning more effective for you. Thank you for joining us in this first part of Clinical Delegation, Leadership at the Point of Care.